It's really my pleasure to be here. And thank you for the introduction, Delaney. I am a heart failure, heart transplant cardiologist by training. I am the medical director for the Heart and Vascular Institute here at BayCare, Medical Group at BayCare. Pleasure to see everyone there. I see almost 50 some people. It's still counting upwards or have joined, so I'm pretty excited by that. I wanted to talk with everyone today about, what we think success means for heart failure. You can see on my slide here, how do we turn heart failure, which is a diagnosis really that never goes away, how do we turn that into a bit of a success for you, right? And so I wanted to kind of a good way of take a little time and see how we can both be on the same page as to what constitutes success for a patient and for doctor. So, the problem is that people think that, oh, heart failure means that the heart stopped or it's about to stop. That's not the case. It really means that the heart is not pumping blood as it should. All right. What happens obviously is the pumping action gets weaker, blood backs up in different areas, for example, the lungs, and can cause cause a little bit of fluid in the lungs and make it hard to breathe, or even in the legs or the abdomen. And that may amount to swollen legs, feet, or kind of a fullness in the stomach. So, this issue with the fluid is sometimes why heart failure is called congestive heart failure. So, the effect on people is important, right? Heart failure is a serious illness. It can definitely affect how long that you'll live, all right? The diagnosis, to be honest with you, is sometimes worse than some cancers. If you look at a 5-year survival, sometimes you have a better chance surviving with a different type of cancer than you do with heart failure. And that's how serious it is. It's not to scare people, but I want to make sure that people understand that this really is something that we've got to take seriously. With proper medications and things that you can do to help yourself, one can live longer and actually feel better. So, it's really important that heart failure be shown as something that can be brought under control. Oftentimes it can't be completely cured, but again, with careful work on your part and some help with a physician, you might be able to really have a good prognosis. So let's start with what you can do, right? So it goes without saying, but I'll say it, you've got to take the medications as ordered by your doctor or nurse. And if you're having problems with those medications or you're having an issue with it, don't suffer in silence. Please talk with somebody and say, hey, I'm having an issue with this, okay? Things like salt and excess water tend to cause that swelling or difficulty of breathing with fluid in the lungs and things like this. So controlling your salt and water intake is something that's going to be very, very important. Stopping smoking, I think it's good for everyone, frankly, but certainly it's definitely something that we want to look at here as well. You want to remain physically active as well, and we'll talk through this a little bit later on in the lecture. Losing weight will definitely help you if you're overweight. Drinking alcohol sparingly, or if even at all, and that's something you can have a discussion with your doctor about, will help you in kind of getting better from a heart failure diagnosis. Checking yourself every day for signs and symptoms of heart failure is important, right? So getting worse, it could be constituted as weight gain. That swelling in your legs or fluid in your lungs is actually, it's water, right? And water weighs something. And so the first thing that happens before you got swelling in your legs or fullness in your abdomen or even shortness of breath is your weight will go up. So weigh yourself daily, okay? Of course, you want to look for the swelling and different things or fullness in the abdomen, and then make that aware to the person that's taking care of your heart failure. These things might seem a bit hard to do, but I think this is essential as part of treatment going forward. So what causes heart failure, right? So in a way, what I want to do is tell you that there's about two different kind of big buckets, right? One is ischemic cardiomyopathy. Well, what does that mean? It's a prototypical person that has heart artery blockage, may have had a heart attack, okay? And that weakens the heart muscle. That's kind of 50 or 65% of heart failure. The other part of heart failure is what we call non-ischemic cardiomyopathy. So it's really not related to coronary artery disease directly or a heart attack, those kinds of things. Could be high blood pressure, could be an infection, a viral infection, could be inflammation of the heart. Lung disease can actually influence the heart and cause a weakening of the heart. Diabetes can also do that. Problems with the heart valves, excessive alcohol, those kinds of things. So those are kind of the areas where it's not the arteries that are causing the problem in a heart attack, but it's the actual effect on the heart muscle itself. Sometimes we don't figure out what the cause of the heart failure is, and that's actually called idiopathic dilated cardiomyopathy. And idiopathic just means we don't know what's caused the heart failure. All right. And we're learning more because a lot of those dilated cardiomyopathies might be hereditary or genetic in nature. And we're doing genetic testing to kind of figure out what is the real cause for some of these people that we said, we don't know what's wrong with you. So we're getting better at that. So, the questions I want you to ask if this is a new diagnosis is what is it? Is it ischemic? Is it not ischemic? Do I have blockages, right? Do I have blockages in my heart arteries? If so, do we need to fix those kinds of things? Certainly, if you come into the heart attack, we want to fix that artery and others appropriately. Is my blood pressure high? Is it under control? Are my heart valves damaged? These are questions you want to ask your internal medicine physician, family medicine physician, or even your cardiologist. The other big thing is to figure out what is the function of the heart, right? What is my ejection fraction? We'll talk about what ejection fraction is here, but the heart itself doesn't pump out all the available blood each time it beats, right? It's got a little bit of blood left in the chamber, sort of to prime the pump, if you will. So it only ejects about 50 to 65% of the blood inside, and those are kind of normal numbers for an ejection fraction. Now, when a patient has an ejection fraction at 40 or lower, we call it systolic heart failure, which is kind of the squeeze of the heart is abnormal. The heart has kind of two phases, and what the heart has is a squeeze, like I mentioned, but it also has a relax aspect, and the relax aspect can have problems as well. And in those cases, most of the time, the squeeze is normal, but the relax is abnormal, and that actually is called diastolic heart failure in the old way, and now we call it heart failure with preserved ejection fraction. And that just means that the relaxation of the heart's abnormal. All right, so a little bit more about ejection fraction, okay? So EF is another way we say it. This is something I want you to ask your physician about if you have a heart failure diagnosis or a loved one does. Now, we can figure it out by a bunch of different ways. Echocardiogram, that's otherwise a sonogram or ultrasound, right? It's the easiest to do. It's non-invasive, jelly on the chest. They put a probe on it, take pictures of the heart. They can look at the walls of the heart, the chambers and the valves and whatnot, and it's very easy to do. Heart catheterization involves X-ray, IV contrast or dye, and that can potentially affect kidney function. Not always. It's not a uniform thing, but the fact is that if you do have some kidney disease, that does affect it. But also, it's a very good way of figuring out ejection fraction. You can do it through other non-invasive ways. One is called a MUGA scan, which is kind of a radio tracer that we use. It's a very small amount of radioactivity that we use in order to kind of understand what the ejection fraction is by X-ray and radio tracer activity. And I think the gold standard, and I think it's really is the gold standard, is cardiac MRI. This is using magnetic imaging. It really is the gold standard. I mean, now, to get into cardiac MRI or to get into a machine, it's a pretty confined space. There are people with claustrophobia may have some problems. It does, have some breath holds in order to get good pictures. It takes about 45 to maybe 60 minutes to do a good cardiac MRI. Again, it's a gold standard. It's very reproducible. It's probably also the most expensive of way of doing it. But again, sometimes there's a reason for doing it. Now, how do we fix all this, right? Okay, I've got this diagnosis. I know my EF. Well, the medicines, right? The medicines are important, okay, again, in the treatment of heart failure. Remember, going back to what we talked about first, and there's a reason I talked about what you can do to help yourself first, because if you don't limit salt water, if you're not active, if you're not taking the medications the way you should, the patient will always win, is what I say, all right? Again, the medications are important in the heart failure. You got to take them, though, right? So again, all medications were under research at some point, right? So all these medications are now really non-controversial. The ones that we prescribe are sort of pillars of heart failure care, okay? So, the heart failure medications can keep your heart working. It helps you live longer, breathe more easily, have more energy, even increase your activity level at times, although, a little bit there, have less swelling or abdominal fullness or shortness of breath. And it's also important that it keeps you out of the hospital. Now, so I'm going to kind of gloss over these a little bit because, I want you to be able to kind of, look at this and you'll have access to these slides later to look at this. But, these are the pillars of heart failure that I'm talking about. The newest one on the block is the angiotensin receptor inhibitor, okay, or neprilysin inhibitor, ARNI. We call it ARNI for short, okay? It's a newer drug combination of this neprilysin business and angiotensin receptor blocker. The angiotensin receptor blockers have been around for a long time, but the combination hasn't. And what we've seen is that combination has helped people to live longer than ACE inhibitors or ARBs, all right? It helps people live longer, decreases hospitalization, and decreases symptoms of heart failure, okay? So, Entresto or sacubitril valsartan is the only medication in this class at this time. I suspect we're going to see some other me too's, and that's good because it may drive the cost down. And I'm certainly a fan of that as well. It comes in different tablet strengths. It's given twice a day. It may actually help control blood pressure as well, and it has some beneficial effects on the kidneys. So this is one thing that we use. And again, that's kind of one that kind of stands on the shoulders of giants, and those are the ACE inhibitors and ARBs. Okay, similar, like I talked about ARNI. You can read this here, so the ACE, ARB, and ARNI are very similar in the way they work. Okay, they block stress hormones that are upregulated when you have heart failure, and improves things, and actually will help kidney function, as I mentioned earlier. Now, side effects for ACE, ARB, and ARNIs could be some lightheadedness, dizziness, decrease in blood pressure, changes in kidney function. You got to watch things, and potassium levels. So again, you got to watch things. That's why you can't just kind of take these willy-nilly. We've got to check some blood work and things like that. ACE inhibitors can cause cough. ARNIs and ARBs don't, which is great. And in rare cases, you may have some swelling in lips and throat and things like this. So again, we want to make sure that we take this with physicians. Okay. The next pillar of heart failure therapy is beta blockers, and beta blockers have been around since the late 1960s and what have you. But we found that in I would say the late 1990s, that hey, beta blockers have been very useful for heart failure. Small amounts of beta blockers and up titrating those medications in a stepwise way has improved people's heart function. The ejection fraction, et cetera, gets better, along with the ACE, ARB, ARNI. The beta blockers do the same thing. But again, look at what we see here. Live longer, go to the hospital less often, improve heart function. You get it. So this is another medication that works by blocking the effect of certain stress hormones, okay? It controls high blood pressure also. It has been shown to improve heart attacks for the 65%, not improve heart attacks, but prevent heart attacks, I should say. But for the 65% that have an ischemic cardiomyopathy, this would be a very, very important medication to take for them, but also the non-ischemics as well. It regulates heart rhythm, and so sometimes we have some good side effects that we want to have. Common side effects that we might have, you see it here, feeling a bit tired, especially when you first start the medicine, or up titrate. That usually gets better. Tough through it. That's what I tell my patients. Tough through it. It's going to get better. The dizziness I want to hear about for sure. And as I said here, it most often occurs when you first start the medication. Rarely we'll see a little bit more in the way of fluid buildup when you first start these medications, but we take sort of painstaking efforts to make sure that that's not going to happen when we start these medications. A little bit of wheezing or shortness of breath might be around if you have pretty bad COPD or asthma. Again, kind of mild COPD and asthma. It's not a contraindication. We use it in those patients, and they do well. Another medication that's kind of a newish on the block, you may have heard of Jardiance and Farxiga. Diabetes medication. It's been interesting as a diabetes medication. Why are we using that for heart failure? Well, it was found initially in the diabetes trial that patients were having less heart failure when they had good diabetes control with the medication, but oddly, patients were feeling better from a heart failure perspective. And so you looked at using SGLT2 inhibitors in just heart failure without diabetes, and lo and behold, it really did improve patients that had heart failure by decreasing hospitalization, improving functionality of patients, and helping symptom control. All right. And the way it works is actually at the kidney level. It blocks the reuptake of sodium and glucose in the kidneys. It kind of essentially makes the kidneys excrete water and sugar. Okay, it does have a mild lowering of blood pressure effect, and reduces stress on the heart. Now, side effects here are important to know about. Urinary tract infection, fungal infections, things like that are important. And so when I start these medications, I will kind of talk about this in particular as in terms of ways of stopping some of those kinds of things, especially if you're prone to those kinds of things as a person. Dehydration, of course, is something to look at when you're trying to remove salt and water and glucose to the kidney. You may have some trouble with dehydration, and so we want to look for that, and that may lead to some dizziness, of course. There's some rare effects on patients if patients are fasting for long periods. Now, this is an old one. Aldosterone antagonist. So the one that is most important is called spironolactone. There's two, spironolactone and eplerenone, and these are actually technically diuretics, but we don't use them in a diuretic way. If I want to get somebody to pee from spironolactone, I might have to use a couple hundred milligrams to get somebody to pee, but we use 25 milligrams of spironolactone or eplerenone, and the reason for that is that we're trying to affect the heart at a cellular level, all right, and improve the way that the heart responds to the thing that injured the heart. The response to a heart from a heart attack or an unknown cardiomyopathy, whatever it might be, idiopathic, right, is to kind of lose its shape and break down the normal shape of the heart. These medications stop that, okay, and cause the heart to be more normal in size. So since they are kind of diuretics, they affect the kidneys as well. So we got to watch things like look at potassium as well, and make sure that there's not too much potassium building up in the system. And that's just done through standard blood work that we would look at. There are some other kind of side effects we'd look at. Oddly enough, in men and in women, we may have some breast tenderness and enlargement. And I think that really would occur in about 10% of people. In many cases, if I even get somebody saying a little bit about that, I'll swap it over to another medication that's similar and also generic that doesn't have that complication. And again, as I mentioned, the potassium levels need to be checked. All right, so we talked earlier about congestive heart failure, right? Why do we say that? Well, we've got swelling in the legs, fullness in the stomach, water in the lungs causing shortness of breath. So a lot of patients say, well, I need to take my diuretic. Oh, you're right. You definitely need to take your diuretic. You need to take the other medications too, because that's actually strengthening the heart. That's actually getting you to be resistant from, kind of building up water. But if you do have water, extra water, so to speak, you might need to take a water pill or a diuretic, right? So we want less fluid in the lungs, makes breathing easier. We want less fluid in other parts of your body, as I mentioned here. And again, taking your diuretic as directed may decrease the chance that you're going to have to go to the hospital or show up at the clinic urgently, that kind of thing. Now, if you take a diuretic, the side effects there is, where you take a diuretic, you're going to have lower potassium and magnesium levels, okay? And so we want to check that. If we need to give you a little supplement of potassium or magnesium, that may be what you need to do, and that's again why we have the blood work to look at this. Now, as patients get better, you can need potentially less diuretics. If we don't reduce the diuretic, okay, you may have the loss of too much fluid, and then you're dehydrated, and then the dizziness and those kinds of things may occur. And so watching your weights daily, especially when you're on diuretic, is important. If you want to want it's kind of nice, even weight. If you gain, I always say, if you gain 2 pounds overnight, or you gain 4 pounds over 5 days, you didn't gain any muscle, bone, fat, skin, or hair. You gained water. nothing, you can't gain weight that fast. And if you do, it's water. I usually say that and patients kind of laugh at it a bit, but it's true. And it's a good way of thinking about it. Fast weight gain is indicative of water. And we may need to, increase your diuretic for a bit in order to kind of get you back down to your normal weight. So diuretic questions. A lot of times patients say, well, I know it helps me, but it makes it hard for me to leave home. How do I go out? How do I take my diuretic? Well, somebody's taking diuretic once a day. I'll tell them, you can take a little bit of liberty here. A lot of times I'll tell somebody, hey, take it in the morning and that's it. But let's say that, I've got a big appointment in the morning. I don't want to take it, but I'm going to be home at 1 p.m. So be it. Take it at 1 p.m. All right. And that way you're getting it in on your terms. And that way you're near a bathroom or whatever it might be. But you get it in rather than skip it. My diuretic makes me get up to go to the bathroom at night. Take it earlier. All right. If you're taking it, take it in the morning. If it's a twice a day medication, take it at, in the morning and take the next diuretic at 1 or 2 o'clock in the afternoon. All right. Talk with your doctor about that. But the fact is that there are ways to get the appropriate doses in and keep your weight stable and keep you out of the hospital. All right. Even at 3 times a day, there's a way of doing it to try and keep you from having to go to the bathroom at night and lose that very important sleep for us. If you take your diuretic as directed and you get worse, well, it's time to start talking about somebody, right? Talking about to somebody. So if you're short of breath only some of the time, should I take an extra diuretic? Maybe not, right? Be careful. You don't want to take too much water out and get dizzy, lightheaded, or possibly fall down. We don't want that for you. There's some other medications that we use. This medication, isosorbate dinitrate and hydralazine. If someone wants to say that 3 times fast at the end, we can definitely get you a round of applause. But these medications are old medications before ACE, ARBs, and ARNI were around. All right, it's helpful definitely in patients that have kidney disease that can't take ACE, ARB, ARNI. We'll use this medication. Okay, it's a combination of pills. All right, there's actually one kind of like a combo pill called Bidil. And otherwise we use it as 2 separate pills. But again, it's one that we use where it's not not a problem if somebody has kidney disease. Okay. Now, interestingly enough, in African Americans, a trial was done specifically in the African American community. In addition to ACE, ARB, ARNI, patients in the Black community that take isosorbate and dinitrate and hydralazine get even more benefit than just taking the ACE, ARB, ARNI alone. And so that's important. That's kind of, again, right sizing the medications for our population. So again, that's interesting for the Black community, and it's something that we do whenever we can in that population, of course. So there's a bunch of other medications. Let's not go through some of this stuff. You can look at these, but these are medications that are kind of second order. The one you might have heard about is digoxin down here. It really makes it mildly makes the heart function better by kind of making it beat stronger, but it also correct a little bit of a hormonal imbalance. It's really not going to make you live longer, but it does have some effect on hospitalization. We see less hospitalization with digoxin. That's one, again, that's been around forever, since the time of Hippocrates, and that's important. The other medications up here, important to think about, and I think this is something, again, that your cardiologist can kind of go over with you as well. Again, well, let's talk about some other things. You might be on blood thinners, potassium, magnesium, I talked about already. The NSAIDs, I want you to avoid these. Okay, because this sometimes causes fluid gain at the kidney level. Okay, so you want to kind of avoid these best you can. Could you take Tylenol or acetaminophen? Absolutely. Okay, but these medications tend to be no-nos in patients with heart failure. Calcium channel blockers sometimes can make heart failure worse. This is something that the heart failure community knows, and the general cardiology community should know. There are some times where we might want to use these medications, but again, in general, we kind of want to be kind of under the supervision of a physician, because not all calcium channel blockers are good for patients with heart failure. You might be on antiarrhythmic medications. There are some that maybe should be avoided, and some people might be on ones that are helpful in some cases, amiodarone and sotalol, and those are important to be on for certain people. If you are taking anything not prescribed by a physician, oral supplements, complementary medications, your coenzyme Q10, your whatever it might be, carnitine, other things, some of those things are probably okay, but you always want to tell your physician about these medications because there might be interactions with these medications with the supplements, I should say, with the prescribed medications. All right, back to what you can do to help yourself. Exercise in heart failure is a completely non-controversial thing. Okay, the key to being active in heart failure is to kind of is to start slow and kind of build up gradually. Okay, if you've not been active, all right, or you've stopped because of illness, okay, get back in, but go slow. I think that's fair. Take a simple aerobic activity involving the large muscles, right? So walking, biking, swimming. I put here elliptical. Some people like to bike outside. Some other people like to bike on an exercise bike. Swimming, great. Gardening, absolutely. Even bowling. So do some activity that keeps you moving. That's the big thing here. Okay. Try and include some walking in any activity plan that you kind of develop. All right. And the fact of the matter is if you're going to start a new exercise program and you've been relatively sedentary, talk with your provider, your physician, that, hey, I'm going to start this. What do you think about it? Is this a good idea? How do I safely go about doing that? So what you want to do is kind of look for about 30 minutes of activity per day. All right. That doesn't mean you got to get on an exercise bike and go for 30 minutes in a row. You could do it 10 minutes 3 times a day if you really wanted to, right? Or break it up. That's kind of the thing. So again, 30 minutes every day is what we're looking for. And I think it's your goal is really increase that activity slowly over time. All right. And if you try and do an hour on the treadmill or something like that, I think it's just going to give you some frustration. It might be unsafe. Those kinds of things. And again, how you start to get active is important too. Again, some of this is sort of self-evident, but it's sometimes just nice to have a reminder. Warming up, okay, allows the system, including the heart, to adjust to the increased demand of the activity you're putting it through, right? And also stretching may help cramping and those kinds of things. And again, cooling down allows the heart rate and blood pressure, et cetera, to kind of slowly drop down towards resting levels. Okay, allows that adrenaline, which is good for you in those times, to come down gradually as well. All right, do it safely. Get some shoes that work well for you, of course. All right, wait a little bit after a light meal to exercise. Obviously, avoid. We know this in Florida, right? Avoid activities or exercising outdoor when it's cold, which is not very often here, but hot. I see a lot of people walking first thing in the morning, especially in the summer, and that's great. Air quality is important too. All right, we talked about warming up and cooling down. We talked about how to maybe begin that. Don't hold your breath, right? I mean, kind of work on your breathing, especially if you're doing some weightlifting and things like that. Kind of breathe, be conscious of your breathing as you're doing any kind of physical activity. All right. So how do you know if you're doing enough or too much, right? So there's this concept called the payback day, right? So the day after you're active, really active, let's say, or maybe too much active, you may feel more tired than usual. Okay, well, that's interesting. That's common. It's called the payback day, like I said. But talk to your healthcare provider if you have this. And then if you think, well, gosh, I did all this exercise yesterday, I felt pretty good afterwards, but I'm really kind of paying for it today. Cut back a little bit. All right. You don't want that payback period. You want to kind of even out your activity to allow for a good, good amount of work. But again, you don't want that payback period as well. Be active with a partner. They may keep you going, right? They may actually keep you engaged in the activity, and that's a good thing. Carry on a conversation when you're doing the activity. That may mean that you're not doing too hard exercise. If you can't carry on a conversation while you're doing things, walking, whatever, you might need to slow down. So that's a good way of kind of rule of thumb about that. Let me shift gears a little bit towards clinical trials. I mentioned earlier that all the medications and devices that we use in heart failure at some point were under investigation. They were a research trial, right? Can you think of of clinical trials as a therapy? And I'd like to say yes, right? So this is where we do a research study where data is gathered about a specific condition, in our case, heart failure. We're talking about that today. The investigator is a medical provider who's in charge of that study, all right? The subject might be somebody like you who's agreed to participate in the trial. The control group kind of gets standard therapy, all right, and not the new treatment. The treatment group gets the new treatment, okay? And patients are randomized, or kind of by a flip of a coin, into the treatment group or the control group, all right? So what are the benefits to being in a clinical trial? Well, patients are living longer lives from successful heart treatments that were the result of past clinical trials. I think my little points are off here, but you can get that. You can be proud that you're helping to contribute to advances in the field, and you'll be helping other people. But the other thing I'm going to say is that you are not a guinea pig. What I mean by that? By the time it comes to somebody like you going into a clinical trial, it's been tried and it's been looked at for safety. Okay, safety is always being looked at, even in a bigger trial. But you're not the first person that would have gone through that trial. There's good follow-up. A lot of times it's a trial that's been done in other countries, and it has a very good safety component, as well as some important data about, hey, that this trial might yield a good therapy, something that might work for you. You may have access to the latest medical advances, okay? And so I think that's important. Risks, of course, are always there. We got to follow clinical principles, ethical principles, where again, safety is the major focus. We look at safety throughout the entire run of a clinical trial. Some patients, if there's no benefit, the Data Safety and Monitoring Board, DSMB, may say, hey, there's no effect on the patient, may not be any harm, maybe there's harm, whatever it might be, but if there's no effect, we're done. And that way, we kind of called the question earlier. Or conversely, if patients are getting a whole lot better beyond a statistical doubt, then we may say, hey, man, we're going to stop this trial early because it's helping so many people. Let's bring that out to everyone, and we kind of go from there. Okay, but I guess this is something that we want to look at. I wanted to bring this up to you as well. And with that, I want to answer your questions. I've been seeing some questions in the chat, so let's start with it.
Absolutely. Thank you for that. That was a great presentation. Our first question, talking about the medications you mentioned in the beginning, they're asking, can these become more ineffective over time if you're taking them, for like a long period?
Yeah, it's like almost kind of the effect wear out. And the answer is probably no. So what can happen sometimes is patients can have a situation where as heart failure progresses, maybe the tolerance of the patient to take that medication will go down. As you might have to cut back on the doses and things like that. In fact, we teach general cardiologists and others that if you're having to back off the doses, that's a bad sign. And somebody like me, an advanced heart failure cardiologist, might want to be kind of talked to about that patient, because it's a bad sign if you're trying to cut having to cut those medications out.
Okay, that's good info. That's interesting. You talked about the MRI. Someone's asking for the cardiac MRI. Does it require the contrast?
Yeah, so the contrast is in many cases it does require contrast, and there are times where you'd use contrast and not, but it's not iodine contrast. Okay, it's a different kind of contrast called gadolinium. There's even a new one actually that's non-gadolinium based, and the newer agents don't even it doesn't even matter if you have poor kidney function. We still have to look at it for kidney function. For gadolinium, but there's again new ones that are not. If somebody has a dye allergy because they got X-ray dye or iodinated contrast reaction, the MRI is different. You wouldn't have that same effect.
Okay, cool. For someone that might have claustrophobia, is an upright MRI an effective option for like this type of MRI that's needed for cardiac?
Yeah, I wish people have done them, but what I'll say is that I don't believe that the imaging is as good as it needs to be able to get good information out of it in an upright MRI. It's okay if you got a knee that you need to do. The knee doesn't move a lot. The chest moves, you're breathing, etc. It's tough.
And what about a CT scan? Is that an option?
CT scans really, we don't want the heart to move a lot. We use it for coronary arteries, for example. There are some places we would want to look at different things. We do a lot of times before EP studies, electrophysiology studies, rhythm studies, but for function, not necessarily.
Can, if you have right side heart failure, are you automatically lower on the list for a transplant?
No, probably, if anything, you might be sicker and higher on the list for a transplant. That becomes complicated because sometimes if you have reasonable right heart function, something like a ventricular assist device, a heart pump that can, be a bridge to a transplant, or if you're maybe too old for a transplant, let's say, could help you to live a good full life and be home and golf and do all kinds of wonderful things, you'd be a candidate for that. If you have biventricular heart failure or right-sided heart failure predominantly, that's a real problem, and sometimes they need transplant as a first line.
Okay. Can AFib cause heart failure?
It sure can. Sometimes it's chicken or egg, right? Which, sometimes we have patients with heart failure that develop AFib, and then sometimes patients have AFib that if it's left unchecked and it's kind of, running along a lot and you're really fast in AFib, you can actually have sort of a temporary cardiomyopathy or weak heart because the heart is really just running away. It's like you're running a marathon sitting still for, months on end, and the heart gets weak. If you can bring the atrial fibrillation under control by medications, by maybe even ablating the atrial fibrillation, whatever the way of taking care of the atrial fibrillation, we actually oftentimes will watch that individual to see if they're getting better, because they will, in many cases, get better, and the AFib is the cause, and they kind of move forward.
For someone that's immunocompromised, does that increase their risk of heart disease? For instance, if you have rheumatoid arthritis or something like something predisposing?
Not specifically, in terms of infection and things like that. A lot of these viruses that maybe affect the heart, they've not been ever shown that somebody that is, like, let's say on methotrexate for rheumatoid arthritis is going to be more susceptible to a virus than another person. So not specifically.
And then to follow that up, can biologic medications like Remicade adversely affect the heart?
There are some medications in that kind of big glut of medications, the IV medications, that we have to be careful with heart failure. It can worsen heart failure. It can cause. So that's sometimes where we do, and I, have a good relationship with a lot of rheumatologists. Because if they notice something like that, then we sort of get involved and kind of come up with a good plan that might treat, let's say, rheumatoid arthritis or psoriatic arthritis and their heart failure, that may make more sense for them.
That makes sense. For if your heart is damaging your liver for like the right heart failure, can it eventually cause cirrhosis of the liver?
It sure can. And we see that in a lot of times children. I'll give you an example. Children with congenital heart disease that have problems with their right ventricles. If they have problems over 10 years like that, the better chances that they have cirrhosis. In fact, we're taught to think that. So if somebody has profound right heart failure for years and years and years, remember I said blood kind of backs up places, right? In your legs, it gives you swelling. Well, it backs up into your liver, and the liver swells literally, and it can damage the liver in that way over months and years.
Can mitral valve regurgitation lead to heart failure?
Again, this is another chicken egg one. Yes.
Yeah.
And so, sometimes if somebody has a real valve problem, the valve's not formed right, or it gets damaged and it leaks significantly, left unchecked, that could lead to heart failure, 100%. Now, sometimes, let's say a person has a heart attack or any reason for a weak heart, and the valve the heart sort of expands. And like I said, the heart really looks like the end of a football. If you cut a football in half, American football, right? It's kind of got that conical shape, right? It kind of goes from that conical shape and it gets more round, right? And what it does is it kind of pulls apart that mitral valve and how it works. And so it tends to leak. So in this case, what happens is it's the weak heart and the expansion of the heart that pulls that normal valve apart. Okay, so in this case, the weak heart might cause the valve problem. So a lot of the mitral valve is important to look at, and that's why I said, hey, ask people about what's wrong with my valves when you go see somebody. But it could be both directions. Sometimes we ignore the valve function. We know it's the muscle of the heart that's giving us a problem, and sometimes we say, hey, we need to fix this valve because it's causing heart failure. So it's really both directions.
That makes sense. Our last question for today, can patients move up and down in the different stages of heart failure? Or once, they're in one, they're kind of stuck, not moving up or down?
Yeah, from a symptom perspective, absolutely, people can move back and forth. If somebody's in the emergency room now, I've got somewhere one of the BayCare facilities, somebody's being admitted with heart failure, and they're huffing and puffing. They're on a gurney. They get IV Lasix from the ICR doctor there, and they're pretty symptomatic, aren't they? And then as they go through the hospitalization, get better, and they're dry and whatnot, they feel better. So they clearly could feel better. Now, when patients start, so from a symptom perspective, people can go back and forth. If a patient has a heart that really gets damaged, let's say they have a heart attack, all right, that muscle is not coming back, and the heart's going to be weak forever and more. It may feel okay, but as the patient goes forward, the damage will always be there, so you can't move back from that. But from the perspective of how the patient feels, yes, they can move back and forth. Does that make sense?
It does.
Okay.
Thank you so much for your presentation and answering all those great questions.
Yes.
Really appreciate your time today. And also for those of you asking for a copy of the PowerPoint, this whole recording is going to be on our BayCare Presents website, so you'll have the whole presentation. Thank you again, Dr. Raval, and hope you all have a great day.
Wonderful. I'll stay on for a little bit and see if I can answer some of these things in the chat.